So all the people logging on, we're just waiting for the attendee counter to run up before we officially start. All right, I think we can get started, even though we're going to have people trickling in. So welcome everyone to this Globe Op Talk. I'm Bina Venkataraman. I am the Boston Globe's editorial page editor. It's my pleasure to host this Op Talk today with Dr. Ashish Jha. Dr. Jha is a physician, a researcher, the director of the Harvard Global Health Institute, a world-leading epidemiologist being sought out for wisdom in all kinds of fora at the moment. And he is soon to be the Dean of the School of Public Health at Brown University, which I'm a bit proud since I'm an alumnus. But so we are getting ready to have a conversation here. And the conversation is about COVID-19, this pandemic we're living in, and about where we go from here. So welcome, Dr. Jha. Thank you so much for taking the time to be part of this conversation.
Thank you for having me on. I'm excited to be here.
So I want to just start with a bit of a question zooming out, because I think we're going to have a lot of questions that go all the way down to decisions that people are making at the very granular level. But I think you and I, based on what I've seen you, observed you writing about, talking about, probably agree that the national response to this pandemic has been at best lackluster, at worst colossally, epically horrible. But where we are now, I hear public health experts raising the sort of prospect that there might be a way to go forward from here that would actually prevent us from having such a bleak fall and winter, that we could crack down for 6 to 8 weeks again and somehow be able to come out with a better situation than what we have right now, with rising cases in much of the country, rising death toll. So what do you make of that? Do you think there is actually a national play here that's left at our disposal?
Yeah, so thank you again for having me here. And it's a great question. And there are a group of folks, people I respect immensely, who understand deeply what's happening in this pandemic, who are calling for a national lockdown of 6 to 8 weeks. And I have not been one of them. And so I want to first make the case for why they are calling for it. And then I'm going to make the case for why, with real respect for these individuals, why I disagree. So the argument for doing it is that we have out of control outbreaks in many, many parts of our country. So you can almost look at the country in 3 buckets. You have the kind of red zones, the Texases, the Floridas, South Carolinas, which still have very, very large outbreaks happening. You have kind of the orange zones of the middle of the country where there's still pretty substantial numbers. They're not as bad as Texas and Arizona and Florida, but still quite bad. And then you have sort of the yellow zones of the Massachusetts, Michigans of the world, which are doing okay. But even here you see cases creeping up. With very, very few places that are truly green zones, like Vermont and Maine, maybe the only 2 states with real control of the virus. So given that picture, the argument is we can't do this piecemeal. We've got to have a national strategy, and a national shutdown for 6 to 8 weeks would bring the levels of virus way down. And then we could open up smartly, get our testing infrastructure kind of fixed up and in better shape, and head into a fall and winter in much, much sort of better prepared than we are right now. I think that is a smart argument. I don't think it's wrong. My kind of disagreement, if there is a disagreement, is that I don't think it's necessary. I do think that the red zones need something close to a lockdown, kind of going back to what the White House initially talked about as phase 1, No indoor dining, no bars, no gyms, no schools, no indoor, no schools open right now. Fixing testing, universal mask wearing. I think if you did that in the red zones, you could really bring cases down. Something similar with a little more allowance in the orange zones, the kind of middle of the country. And then for us in Massachusetts, Rhode Island, New Hampshire, Michigan, I'm not gonna list all the states, but New York, that you need a dimmer switch. That like cases have started rising a bit too much in Massachusetts. And so we need to pull back a little, but we don't need to go to a national shutdown. I think there is a way and a path to do this in a much more nuanced way. But I am fully aware that if Texas doesn't manage their outbreak, it will make it harder for Massachusetts to manage ours. And so because we live in this country, I am sympathetic to the national lockdown argument, but I have felt that largely we don't need to do it if we're willing to do the hard work of having much more customized policy.
So you've been on academic campuses for much of your career. You're about to shift from one New England campus to another. Do you think that are you taking into consideration? I'm sure you are, but how do you account for the movement of students from different states around the country into places like Boston, like Providence, where they could be bringing new infections to places that are perhaps in the yellow zone now?
Yeah. So it's a great question. And in fact, this is one of the arguments for having a national policy. And let me be very clear. I have been advocating for a national strategy from day one. So it's not like I don't believe we should have national strategy. I just am not convinced that we can develop one right now that will be effective and work everywhere. In terms of college campuses, so I have been thinking a lot about Brown University, but you could argue the same for Harvard, for Northeastern, for BU, all of these places, that there are going to be kids coming from Florida and Texas and Arizona. And you have to work with the assumption that many of them are going to come in infected. And so we need a strategy for quarantining. We need a strategy for testing. And we've got to have a very aggressive testing strategy so that they don't become unknowingly vectors for disease spread in the community. I do believe that we might see a little bump up in cases with all those new people arriving here. As long as we have a strategy for managing it, we can keep it under control and not have it spread into the broader community. So I think it's entirely manageable, but I think we've got to pay very close attention to it.
So is part of your skepticism about the 6 to 8 week lockdown idea, are you reacting in any way to seeing how the quasi-national lockdown of the spring kind of was squandered by national leadership? It seems to me that had that time been used to really develop a national testing strategy, a strategy around safe reopening that actually could work and involve contact tracing and so forth of new clusters, that maybe we'd be in a different place. I mean, is part of why you're arguing against that because you don't see the logistics or the operations being able to come to the fore?
It is. So it's like there's nothing wrong with a national lockdown policy idea. It's a good idea. It's perfectly reasonable. But every time I have thought about policy, and not just in this pandemic, but in my entire career, I've thought about policy in two ways. One is, does it theoretically make sense? Would it work kind of in the ideal world? And then what about the execution risks? And what about the ability to actually do it with a high degree of fidelity? And I have so little faith in our execution risks to pull off a national strategy on this. And I also just don't believe that the president would do it. And then the president, what he did with the last shutdown we had was, while his White House task force was developing a smart plan for reopening America, he went and undermined it by telling people to open up and not pay any attention to his own task force. So when I look at all of that, I think, can I justify to, let's say, the governor of Michigan, that you should shut down, given you have relatively low caseloads, a 2% positive rate, when the president might in 2 weeks start undermining it and the governor of Georgia is not likely to adhere to it? That strikes me as the situation we're in. So some of this is not critique of the policy in theory, it is real skepticism of our ability to pull it off in practice.
Makes sense to me. I'm going to want to get back to the issue of schools, but I want it for a moment. Just think about people in their lives and people trying to grapple with the level of uncertainty we have about when things are going to get better, when things are going to get worse. It seems to me there are a lot of public health experts talking about how bad things could get in the fall and winter when this compounds with flu season, when we're indoors more. How should people be thinking about making decisions in their lives? I think there are some of us who have had in our minds, whether it's conscious or subconscious, this idea that we'll stay really, really cautious and really, really careful, maybe not even see anyone except for the occasional 6-foot distant gathering in the backyard until there's a vaccine. We'll do this, we'll hold out. And just let's keep everything closed, keep it on a tight leash. Obviously, this is not universal across the country. There are people who are gathering, going to concert halls, having weddings. We see those news items. But for people who are sort of kind of keeping in their mind, there's going to be a normal at some point when there's a vaccine, and let's just stay really safe for now. Is that the mentality that you would encourage in light of what you see, in light of what we can expect from a vaccine? Can you help people kind of grapple with that?
Yeah, it's a really good question, and it's got sort of 3 or 4 parts to it. So let me see if I can take them on. I mean, one is there is one group of folks who just have this mindset of the vaccine's around the corner. Let's just keep everything kind of tightly locked down. The vaccine will come and then life will go back to normal. That is almost surely not how it is going to play out. So I believe, and I actually on the vaccine issue, I have been among the most optimistic in terms of timeline, what the vaccine will do for us. The consensus view that I believe in the public health community is the vaccine will arrive sometime in spring to summer of 2021. It will not be necessarily particularly effective, and that much of 2021 will continue to be a struggle, maybe better than 20, but not anything close to normal. I'm a bit more optimistic than that. I believe we'll have a vaccine with reasonable data on safety and efficacy late this fall, November, December. We will have, but it'll take several months before we will have 100 million doses. I know Operation Warp Speed is trying to move that forward, and I think it'll make clear progress. And I don't believe that the vaccine is going to be 98% effective. I think the vaccine might be 80% effective or 90%. It'd be great if it was 90, but it might be 75, 80% effective, in which case it will slow down the transmission, but will not make the virus go away, and it will not bring our lives completely back to normal. And we will need to continue doing some of these public health measures.
So when you say,
please.
Say a little bit more about the basis for your optimism. You have a timeline that looks more like Dr. Fauci's than some of the other experts out there. Can you say more about why you do that?
We're just moving at an unprecedented pace. And, we're in phase 3 trials for 2 different vaccines. China's in phase 3 trials for a couple of theirs. And the question is, how long is a phase 3 trial going to last? And the answer is, I don't know. It'll last until we have the data that we need. But with 30,000 people getting, half of them getting vaccinated, it should be enough exposure, especially if you're doing it in a lot of the hot zones of the United States, that we should start seeing an efficacy signal in November. Could it be December? Absolutely. Could it be October? Maybe. Seems unlikely, but maybe. But somewhere in the November, December range is when we should have enough data on efficacy. And I suspect we'll also have reasonable data on safety. Obviously, we'll want to continue monitoring for safety for some period of time. But I can imagine in late November, December, healthcare workers starting to get vaccinated, and other sort of such contacts. So it's really based on how quickly we've moved and how promising the data seem to be. But the one clarifying point on this is all the data we've seen, I think of it as sort of like, it's the prep stuff. It's we've been playing in the minor leagues, and the minor leagues, things are looking great. But when you show up at Fenway Park, that's phase 3. That's the big game. A lot of things can go wrong once you actually show up in phase 3. So I don't want to be overly optimistic, but I look at the phase 2 data, phase 1, phase 2 data, and I'm so heartened by it that I have to believe one of these, maybe multiple of these vaccines will make it through phase 3 in good shape.
And you made an important corollary point there earlier before I asked you about the basis for your optimism, which is that when we do have a vaccine, it may not be, or set of vaccines, it may not be as protective as we would want it to be in order for life to return to what it was like before the pandemic. And so the people are still going to need to adopt certain precautions and public health measures. Given that time horizon is so long, we had a number of readers who are going to be watching this today that are watching right now, probably, that wanted to know about making certain kinds of life decisions, how you would reason through them as a scientist who's been watching closely what's happening in this arena. And they involve questions like, let's start with the very old, people in their golden years, their so-called golden years, who had been hoping to live this time of their lives, the span of the next year, the span of the months that have passed this year, being able to travel, being able to see their grandchildren, being able to see their friends, have dinner parties. Yet they're also a high-risk group, we know, for COVID-19. And so how should they go about thinking about this? When we were thinking about it in April and March and thinking maybe we need a few months of lockdown, maybe things will get under control in this country, I think it was a very different set of risk factors and decisions facing people like that. Now that we know that it might be some much longer time, how do you think people should think about that?
Yeah, it's a really good question. And there's so much that's frustrating about our botched national response that is making all this much harder. So I think about my own elderly parents. They're in New Jersey. I haven't seen them, and my kids haven't seen them since, I think, early February, early January, but some period of time. And I don't really know that they will be able to see them, not in a normal way. I mean, in the sense that I can imagine, and I've been talking to my parents about this, of them potentially, of us going and visiting, but not spending the night there, not spending time indoors, seeing them outside. I mean, these are the kinds of ways in which this stuff is doable and feels pretty safe. It would be a lot easier if we had widespread testing available that was sort of cheap and could give us results back, right? Because then you'd feel much better going and seeing elderly people who are at higher risk. So that has been our inability to control the virus effectively across the country and our inability to really have the kind of testing infrastructure we need. That combination, to me, has made all of this stuff much, much harder. What I have said to my parents is I expect 2021 to be much better. It may not be right away, may not be in January or February, but as the year goes along, I do think we'll have far more testing widely available. That'll make it much safer for them to come visit us and us to visit them. And then obviously at some point in early to mid 21, we will have a vaccine, which hopefully will bring down. So all of it will lead to more safety. But if we had had a much more effective response in the way that all of us were asking for back in March, life could have looked much different right now, but we didn't. And we still continue not to. And that necessarily means that probably a year of people's lives, of those golden years, I think in some ways are going to be spent not the way that anybody wanted it to be.
It's tragic too. I think about my parents as well. We're probably watching this. So I am curious in terms of testing, are there states, we've heard about Governor Baker here in Massachusetts. I think we have an audience right now that's national, not just regional, but I think we should talk a bit about Massachusetts for our readers. And I mean, we have had a testing strategy here. Is it still not up to par in terms of offering those rapid tests that would allow people to do things like these visits?
It's still, excuse me, so Massachusetts is clearly doing better than a vast majority of states. It's still not where it needs to be. And I say that in a couple of different ways. So let's talk about the good side first. We have a 2% positivity rate. That to me means that we're casting our net pretty widely. When people need a test, they can largely get it. But I still, I'm hearing lots and lots of stories of people who want to be able to get a test before they, let's say, go visit their elderly parents or something, and often have to book a week in advance. The results are not available immediately. I still believe that Massachusetts can and should be leading the nation and be getting to a point where if I wanted to go get a test this afternoon, I should be able to get one and I should be able to get results back in 24 hours. That's where we should be as a Commonwealth, and we're not there yet. And so I believe there is work to do. So Good news is Massachusetts is doing better than most states. There are states doing better than us. But
you're Governor Baker right now. What would you be doing differently?
I think if I were Governor Baker, I would be doing a couple of things. I mean, one question is, have we really brought online all the capacity of all the private labs, all the academic labs? If we have not, what's preventing us? And how do we make sure that we have the kind of resources flowing, both intellectual, regulatory, and financial resources flowing, so that we have much more of that testing capacity? And the second, and the governor, again, has done a good job of partnering with those 6 other states to buy the Anagen testing. Anagen testing has become more available here. I would keep pushing on that and make that much more widely available as well. Specifically for things like schools and colleges, where I think antigen testing as part of a surveillance system is quite effective, can be quite effective. So again, I think it's doing more of what he has done. There isn't something massive or major he's missing. I would just push him to do more of it, because I think we need more testing in Massachusetts.
So let's talk about schools, the very young, not the college campuses. You wrote this wonderful op-ed for the Globe, and we hope you'll write again, about sort of some empirical measures that communities could use when school districts are deciding whether to reopen in person or to continue with remote learning or hybrid models in the fall. And you wrote it a few weeks ago, and there's been some amount of new data, let's say, just from the point of view of schools in Georgia that have reopened and then found they needed to shut down again because of the spread of COVID. The measures you talked about were having low prevalence rates in the community, low positivity rates, so low numbers of positive infections coming from those who were tested. And you talked about some ways that schools themselves should go about controlling infection, testing and tracing teachers and students often, spacing people out, all those kinds of things. Has your view changed at all since setting this out and since seeing what's happened with some of these school closures about what you think is the responsible way to think about balancing the loss of learning for students and public health?
So largely, I would say has not changed. And if anything, my argument for having a lower threshold for younger kids and really making an extra effort for younger kids, K through 5, to get back to school, I think has gotten strengthened by some new data that's come out. So there's been at least one more study from South Korea that really makes the case, and if you read the evidence carefully, that young kids do not seem to transmit much to adults. Do they transmit at all? They do. But they do not transmit much, and it clearly appears to be lower levels than older kids. And where's that cutoff? 10 is what the South Korea study used. So kind of fifth-ish grade, but something in that range. Okay, so when I look at Georgia, I think what has happened in Georgia was completely predictable. It's in fact exactly what you would expect. Georgia opened up irresponsibly, I believe. They went sort of against where the science and data were. They didn't even ask people to wear masks. It was voluntary. We can't have voluntary mask wearing. We should expect that all the kids and all the adults are going to wear masks. If there are problems with some of the youngest kids being able to wear a mask, like, let's work on that. There are alternatives. They're not going to be as good. But my sort of overall feeling on this is that we have one shot at opening schools this fall, because if we open irresponsibly, there are large outbreaks and schools shut down again, they're going to be very, very hard to reopen. Everybody's going to be much more gun shy. So we should open responsibly. So what does opening responsibly mean? It does first begin with community transmission, as you said. And Massachusetts meets that criteria. Now, there isn't a formal definition. And this will get to a broader point, which is there is no like set point at which you say, okay, it's totally safe, do it. There is only safer and less safe. Georgia, clearly unsafe, less safe. Massachusetts in the safe range overall. Again, some communities more than others. I do think mask wearing should absolutely be mandatory. I think what I have said to folks is we can't look at this as an all or nothing. So let's, like, if you don't have great ventilation in your schools, keep working on that and try to have classes outdoors in September. And then people say, well, what if it rains? Okay, on those days, people will be at home. Like, you're not going to get it perfect. But if you can get a good number of in-person instruction days in September and October, use that time to really get schools ready. You can get kids back into school in November. And if you aren't doing outdoors, a lot of schools can go back in September. But my point is, try to maximize in-person instruction. And if we end up having a terrible flu season, and if COVID comes roaring back, and if in December we have to go online for December, January, February, at least we got a few months of instruction in. It's all about trying to maximize that in-person instruction. There are lots of ways of doing it. We have to be creative. I've been saying to school districts, like, use your libraries, like use libraries as classrooms if you're running out of space. Use other municipal buildings where you may not have workers going back in. We should be creative about getting kids together. And I think if we do it with good science, mask wearing, reasonable ventilation, we can actually do this pretty safely.
So I can imagine some skepticism from listeners who might be thinking, okay, well, what about the risk to the teachers and the custodial staff? Should teachers have a choice whether or not to go back in person? Should teachers or students who have multi-generational households, who are from communities of color where the risk of COVID is higher or the death rates are higher, should they have different sort of toggles or different kinds of options? What do you think about those questions?
Yeah, so every time I talk about safety, I don't mean just the kids, because I am really aware that you need teachers and staff to run schools, right? You need adults. And my mom was a public school teacher in New York for 25 years. And every time I talk about schools, I usually get a phone call from her who wants to make sure that I am thinking about people, you know, who were her friends and who are her friends in school still. And of course, so having teachers get sick would be an absolutely horrible outcome and would also shut down school. So this is not about kids. This is about kids and adults interacting together. And it has to be safe for adults as well. I think on the issues of communities of color, this is it's a complex topic for a couple of reasons. One is what we have learned from going online in the spring was that there was a massive kind of widening of the standard equity gaps that we see, where some kids were able to jump online and do reasonably okay, and a lot of kids were not. And the kids who were not disproportionately came from poorer backgrounds and from minority communities. And there is no question in my mind that if we are online for the next 12 months, that what we're going to see is a pretty substantial widening of the achievement gap between more privileged kids and less privileged kids. I'm also pretty clear that what we're going to see is pretty substantial labor market effects on women, because whatever we may say about gender equity and kids, the reality is that women end up bearing the disproportionate brunt of extra childcare. And that will have real effects on women's earning potential, their jobs. None of that means we should do this willy-nilly, but it does mean that we have to be thoughtful, and defaulting to just being online for the next year because it feels safer should be seen in the context of the very substantial costs that are going to come on both gender equity as well as on racial and ethnic equity in kind of our society.
Balancing different risks there, really interesting. I want to ask about your personal experience. We're going to bring in some of the audience questions more directly, some of which are coming in live. In a moment, I'm going to invite our deputy op-ed page editor to join us for that. But you know, you have obviously you have a public facing role at Harvard at the Global Health Institute, but you've really stepped into the limelight a bit more during this pandemic, if I understand correctly. You're on TV quite a lot, and you're doing a lot of public communication. What's that like for you? And also, why are you doing it?
Yeah. So it's a little strange, just the sheer amount of media that I do. It's strange in the sense that I've never done anything quite like this. But then we've never been through a pandemic like this, or not in a century, and so certainly none of us have. You know, the request sort of for media engagement is like very large. I probably say yes to about 10-15% of what I get asked to do. And I, for a little while, really started wondering, am I doing good? Is this a good use of my time? Shouldn't I be spending more time doing more scholarship, more analysis, more writing of academic papers? And ultimately concluded, based on feedback, I actually went out and talked to lots of people that I knew, both in Boston, but across the country, and asked people's thoughts. And the sense I got was that there is a real gap in good quality public health information and good quality public health messaging. And I felt like if I could help fill that gap, if I could play a constructive role in communicating the science to people in a way that was both credible and helpful, that was an important role for public health leaders to play. And so ultimately, I have decided that it's a good use of my time. I enjoy doing it. And as strange as it is to be as public as I am, as long as I feel like I'm being helpful to our country, my take is I'm going to keep going. And the day that I feel like I'm not, I'll be happy to stop.
We were chatting before the op talk about how you felt that, if the CDC, if we had public health voices that were truly prominent in this country at the national level, it might not be as necessary for others to fill the gap. But we're grateful to you for filling some of that gap, to you and your colleagues. I'm going to ask Deputy Op-Ed Page Editor at the Globe, Amy McKinnon, to join us, and because we had an overwhelming and incredible array of reader questions for this op talk. So Amy, take it away if you want to tell us some of the reader questions.
Hi, everybody. We received hundreds of questions. Thank you so much. Dr. Jha, one of the questions we received was, who will get the first few rounds of vaccines if or when it becomes available? And what does it take to achieve herd immunity?
Great questions. So I think the strategy for the rollout is still being worked out. There are national committees that weigh in on this. This time around, we're making sure that, and I'm not, this is the White House is helping lead this, that we have ethicists and we have a whole array of folks who are helping set that policy. So I don't know the answer. We'll see what the rollout plan looks like. Almost surely, healthcare workers, frontline, first responders will be among the very first to get it. And that makes total sense. Beyond that, there will be important questions about, do you put older people in first because they're the highest risk, but they're also less likely to get an immune response? Or do you wait later until there's a higher level of population immunity to vaccinate them? So there's a lot of work being done. My hope is that it's driven by science and protecting people, and that we don't, and I suspect it will be. And so I'm hopeful that we'll have a good plan, but I will reserve judgment on the plan until I see it.
And what about herd immunity?
Yeah, in terms of herd immunity, so there's a simple answer, which is almost surely wrong, and then there is like a bit more of a complicated answer. So the simple answer is 60 to 65% of people have to have immunity either through natural infections or through vaccination. That's what the epidemiologic models tell you, and maybe it's 70, maybe it's 60, but let's say 60 to 70. The reason I say it's almost surely wrong is that it's much more dynamic than that. And what we should not think of is that there's no herd immunity, there's no herd immunity. All of a sudden you hit a 65% magic number and then boom, the virus goes away. Doesn't work that way. What will happen is as proportion of people who are infected gets higher and higher, the population immunity builds, the dynamics of the virus start changing. We will start seeing a slowing of the spread. When the herd immunity level is reached, whether it's 60%, it could easily be a lower number. It's entirely possible, not only possible, it is likely that infections will continue. It's just that it won't be able to sustain itself and get into exponential growth. We'll also have micro communities where the proportion of people who are immune are much lower. So you can imagine, and I'm making this up, that you can imagine in Boston, it could be 85% of people have immunity, but in Western Texas, it's only 30%. Well, as a country, we might be at 60 or 70. We'll see local areas with big outbreaks. So 60 to 70 is kind of the official answer. Most of the dynamic models suggest it's lower than that. But the big point is, I don't want people to see this as a kind of threshold and we hit it and everything is better. It's much more dynamic, and things will start getting better once we get to the 30, 40% infected range.
Great. And based on our knowledge of similar viruses, is there a way to gauge the long-term health outcomes in COVID-19 patients who survive?
Yeah. So we don't have very many good models for other diseases. I mean, obviously we could think about SARS-CoV-1, the original SARS of 2003. But this virus really does, I mean, first of all, this virus has infected a whole lot more people than that virus did. And much of the data we're seeing suggests that there are a large proportion, and I don't know what that number is, maybe it's 20, maybe it's 30%, but some large proportion of people end up having significant longer term effects. So the classic, like you get infected, you have 5, 7, 10 days of symptoms, and then you're better, and then you're back to normal. There are a proportion of people who have that, but as a pretty small group. There are lots of folks. Well, I shouldn't say it's a small group. What we know is about 20% are asymptomatic, pretty much never develop symptoms. Another 30–40% might be in that group that have the acute infection, then get fully better. But it does seem to me like there are 20–30% of people who really have persistent symptoms, weeks or even months out. And we don't know the long-term effects, because obviously we don't know the long-term effects of this virus.
Yeah, that's pretty terrifying. And this is, I thought, was a great question. Would you please clarify the different tests, antigen, PCR, and who should have what?
Oh, it's a really good question. So first of all, there's the antibody tests, and I want everybody to stop thinking about the antibody tests because it's gotten way too much attention and it does way too little good for most people. It's super interesting for people like me when antibody tests get done, because it tells me something about the kind of broader population level spread and where it's happening. But most people should not be going out and getting antibody tests. Okay, so different from antigen. Antigen tests, relatively new. There are 2 of them that have been approved by the FDA. And they have much lower sensitivity, meaning that of the people who are infected, they're less likely to get picked up by the antigen tests. That said, there is good reason to still use them. We think when people are really infectious, so not only are they infected, but they're spreading virus, the antigen test tends to do a pretty good job of picking up people. So I think antigen tests are good for symptomatic people because they tend to have higher viral load. And they are good for surveillance. So I would be very comfortable using antigen tests in schools, because even if you miss somebody one day, if you're testing, let's say twice a week, you'll pick them up in their infectious period. And so antigen tests are fast, they're cheap, good for surveillance, good for people with symptoms. PCR test remains our gold standard. That's what we've been using from the beginning. We're doing 700,000 to 800,000 of these a day. These are the ones that are getting slowed down now. They tend to be more expensive. They take longer to come back, but they have been the gold standard. And then the other thing I'll say is that there are 2 or 3 others that are right around the corner. One of the most exciting to me is genomic sequencing. There's a great company here in Massachusetts, Ginkgo Bioworks, that has just led the way on having genomic sequencing as a mechanism for doing testing. Should be very, very sensitive. Again, we're waiting for some data that they're I think they're filing with the FDA. I don't know for sure, just that's my basic understanding. But there's, from what I have heard, I think they've got great data on sensitivity. So my point is, there's a whole array of new tests coming. Right now, it's antigen and PCR as the 2 main games in town. They're not interchangeable. There's a real role for antigen testing, but we shouldn't use it for everything.
Is there a rapid, effective, or accurate test on the horizon as well?
So Michael Mina at the School of Public Health has really been fabulous on this, has been kind of one of the national leaders in thinking about these rapid tests. There are some CRISPR-based tests, these tests that you essentially little paper strips that are also kind of, with the technology for CRISPR, for some of these things are available. They just haven't kind of ramped up yet. So I do think there is a time in the future, and I'd like it to be the next few months as opposed to 9 or 12 months from now, where I could imagine you spit into a cup, you drop a piece of paper into it, and you get a result in 10–15 minutes, and it's pretty accurate. That would be extraordinary. It would be a game changer. It would completely change our lives. That technology exists. We have not chosen to ramp that up and make that as widely available as it should be.
And so if we were to remain on track, the US were to remain on track into the fall, what do you expect the fall to look like based on COVID infection, flu, and the myriad other viruses that people contract?
Yeah, so the fall, there are 2 views on the fall, and I'm going to lay out the more pessimistic one first, and then I'll tell you why I'm a little bit more optimistic. But I think the consensus view is we're going to go into the fall with much of the South still with kind of raging wildfires, large chunks of the middle of the country with a high number of cases. We have seen that creeping up of cases in the Northeast. And then we hit the fall, people start spending more time indoors, the flu season arrives, the hospitals start getting full because of the flu, throw on COVID on top of that, and we have a horrible fall and winter, lots of people dying, hospitals in big trouble, and we're largely shut at home. That is a view that lots of very smart people believe is most likely. And I get that. And I am more optimistic than that. So let me at least make the case for a more optimistic picture. But take my optimism with a grain of salt, because lots of smart people disagree with me. I think that things are starting to get better in the South. I think that entirely possible that people are going to start. I mean, again, we've started seeing more mask wearing. We've started seeing better compliance with a lot of these public health measures. Even in Massachusetts and Rhode Island and other states where the case numbers are low but creeping up, we've seen governors act. Governor Raimondo, Governor Baker pull back. And so I am optimistic that these governors are not going to let things get out of control in these states. I'm optimistic that we're going to have a whole new set of technologies around testing, which will make testing much more widely available. Genomic sequencing that I mentioned from Ginkgo, more antigen tests, some of these CRISPR tests. And I'm also hoping that all the social distancing we're doing, hand washing, et cetera, will make a real difference in terms of flu spread, that we'll end up having a much milder flu season. That's what we have seen in the Southern hemisphere, where the flu tends to hit first, right? Because they're in their winter. They've had relatively mild flu seasons because all of this stuff is actually playing out in terms of reducing flu spread. And so my optimistic view is we go into the fall and winter, if we do our job right, in reasonably good shape. Hopefully we have a good flu vaccine, which everybody should take. And then and then maybe by November, December, or into January, we start getting a vaccine. Some people start getting vaccinated and life starts turning around for a bit better. Not normal, but that we can get through the winter without too much suffering.
And one final question. Can you talk about coronavirus mutations and what the risk is that this may stick around beyond any sort of end date that we're hopeful for?
So I'll start with the second one first, which is it probably will stick around. I mean, smallpox remains the only virus that we have eradicated from the planet. I mean, not from the planet, it's in some labs, but it doesn't affect humans. I don't expect that to happen with SARS-CoV-2. I expect this virus to be around, and I expect it to infect people with some frequency, and especially because we don't expect that 100% of people will take the vaccine, and will have the virus get introduced from travelers, and within our own country, it'll circulate. So it'll be with us for a while. The question is, can we get to a large level of population immunity that most of us can get much of our lives back? And I think the answer to that is yes, at some point in 2021. In terms of mutations, viruses have mutations all the time. We see, that's actually how we track virus spread, as we look for little tiny mutations. The big question is it enough to be called a different strain? And that is much more functional than it is genetic. And when we talk about different strains, we're talking about viruses that are either spreading more quickly because they might be more infectious, they might be more deadly or less deadly, they might have different clinical manifestations. So far, we have not seen that with SARS-CoV-2. Now, there is this sort of European strain that people talk about that may be more infectious. And some of the leading virologists that I follow and talk to disagree on whether this is just truly a different strain or it's just kind of a pretty standard classic mutation, not much functional difference, but just happened to take over much more in Europe. But the big picture point is, I'm not worried about this. I'm not worried about some mutation that will make it so that our vaccines don't work. I'm not worried about a mutation that will make the virus much more deadly. I do think the virus is going to be around with us for a while. Those kinds of mutations can happen, but this coronavirus is not one where I'm particularly worried about that. So I suspect the virus we have is the one that we'll be living with for a while. And we've got to deal with it with a vaccine and with all the public health measures that we know work.
Dr. Jha, can we keep you for a few minutes?
Yes.
After we've had so many good audience questions, I hope you don't mind.
Nope.
I have two more questions for you. Actually, I have a million, but I'm gonna narrow it to two. One is very practical and the other one philosophical. And the practical one, as I hear you talking, that I imagine beyond a lot of people's minds, is just if this picture could possibly get a lot bleaker in the late fall and winter, is now the time that people should be taking those sort of mitigated risks to travel to see families? You talked about that in the context of schools reopening for September and October before going back to remote learning if necessary. Is that the way people should be thinking about sort of decisions in their lives, seeing relatives, that sort of thing?
It's a great question. So I think it depends a lot on where you live and what the situation is. But in Eastern Massachusetts, in much of the Northeastern United States, this is a reasonably good time. So if that fall, the more bleak picture ends up being a reality, and it is a possibility, then this is a better time to do it than probably November or December, where the case loads may be higher and it may be more complicated. So yes, I think that's a pretty reasonable way to think about it.
Good to know. And then the other question is just, I think I share your love for data-driven decision-making and sort of the idea that the evidence base and the science should shape the response and the decisions that happen at the political level, but as well as the personal level. But I'm just curious how you think through how we do that at this time when the data are emerging. There's a lot of uncertainty. There's disagreement that you've pointed to in multiple spots between the experts on how to read where the scientific data are taking us. How do you really think about what's the best way to make empirical data-driven decisions in this time?
Yeah. So I think of this in two buckets. There is misinformation, and then there is like disagreements among experts on real information. So the misinformation is massive. And people who promote that misinformation, often through social media platforms like Facebook, what they will do is they will pick one piece of data out of context and promote it as though it were suggesting something not what it is actually suggesting. I always find it interesting whenever I tweet about something around immunology and the immunity around this virus. Like last week, I got some finance guy from Laredo, Texas, tweeting at me about T-cell immunity. And I thought T-cell immunity is really complicated. I barely understand it, and I'm not even sure I really do. I'm not sure how this finance guy from Laredo has become an expert on T-cell immunity. That kind of stuff is misinformation. We got to try to really ignore that. Where experts disagree is really on the margins. What I have been really surprised by is how much general consensus there is. So, I don't think we need a national lockdown. But I look at what Mike Osterholm or other people are saying, and I think I get why they're saying that. And the key for most, I think, Americans is listen to experts. Where they disagree, understand why they disagree. It may be something kind of on the margin. But the broad consensus in the public health world is, we know what to do to get through this period of time, right? Wear masks, avoid indoor gatherings, let's fix testing. Let's do those sort of 4 or 5 things that are going to keep this under reasonable control. And then different people will vary in their values on what kind of risks they're willing to take. But as long as they're doing it based on information and not misinformation, I think that's reasonable. We don't expect everybody to do exactly the same thing, but really trying to disentangle what is junk versus where is there substantive disagreement because the evidence is such that reasonable people can disagree. I think that's really, really important.
A challenge for our whole democracy, not just for the pandemic, but beyond. But thank you so much for being so generous with your time and your insights about this. I'm sure it's been a huge help to so many people. And thank you for your work, Dr. Jha. Thanks to everyone for tuning in.
Thank you.